Hello everyone and welcome back to the HP Leader YouTube channel after that very short break. Now I really hope we've set you up nicely talking about the data, the science, the epidemiology of long COVID, some lived experience from Dr. Asad Khan as well. So I am delighted now to be joined with this fantastic panel of multidisciplinary expert professionals who are going to be talking to us today about everything long COVID and what they do. So I'm going to ask each of the panel to go around and introduce themselves, starting off with Lizzie, please.
Hi, I'm Lizzie Davey. I'm a clinical psychologist. I work in North Cumbria. My background's working in pain management, CFSME services, and with people with long-term conditions.
Thanks, Lizzie. Over to you, Gemma.
Hi, I'm Gemma Clooney. I'm a speech and language therapist working at Imperial Healthcare Trust in London. My background is airways and ENT work. I'm actually currently on secondment doing an NIHR clinical doctoral research fellowship as well.
Thank you so much. Aaron?
Hi, I'm Aaron Boyson. I'm a dietitian. My background is in respiratory and a little bit of ICU recently, but I am also one of the dietitians in the long COVID clinic, and I've been for the majority of since the middle of last year.
Thank you. And last but not least, I'm delighted to introduce my fabulous co-chair, Raz. Raz, if you'd just like to tell us a little bit about yourself and where you're from. Thank you.
Hi, I'm Raz Kahai. I'm a cardiorespiratory dietitian working in London, and I'm really happy to be co-hosting with Rachel today.
Thank you. And Raz is going to be leading the questions at the end. So as usual, please do pop them in the YouTube chat. Tell us where you're dialing in from today. Any questions at all, and all of the presenters are on social media, and I'm more than happy to answer questions. So we're going to start with our first presentation. So over to you, Aaron. And we will then move swiftly on to the speakers and ask all questions at the end. Thank you so much. Oh, we've got no volume from you there, Aaron.
Okay, now?
Yep, got it.
Brilliant. Okay. So I've come a presentation of nutritional considerations in individuals with long COVID. Now, I am a dietitian in one of the long COVID clinics. I do not by any means consider myself an expert in this area, but I do have several months of experience and working with patients and helping them to manage sort of nutritional issues related to symptoms, related to the symptoms they're experiencing due to long COVID. Now, often people will ask me, and I don't know anyone saw the Channel 4 Dispatches documentary. I was asked by one of the producers, what are your recommendations for people with long COVID? And they wanted like a pithy soundbite. Well, the real answer is it depends. It depends on lots of things, because of the diagnosis criteria as set out by NICE guidance, and I think it has lots of benefits to also being quite an umbrella term that helps to captivate lots of individuals. I mean, often the people in this group are people who are suffering with continuing COVID-19 symptoms, organ damage. Some of them are suffering from post-viral fatigue-like syndromes, and some of them are included in there. And I don't know how post-intensive care syndrome as well. And it's sort of all of those that patient cohort is within that category. And obviously, in order to get sort of the care and support that is limitedly available, often I think the wider net is often helpful as we further develop our understanding of this condition. So there's going to be a multitude of people with various different backgrounds, and also so the previous admission they've had, the impact of the symptoms on that person's individual life and how that impacts them. The financial resource that they have and the available support, whether that be through family, be through friends, because that can have a major impact on the kind of symptoms they're actually experiencing and how much it impacts their nutritional status. So what kind of things do I actually do in the long COVID clinic? So when I first started, I decided I wanted to do a comprehensive assessment, as comprehensive as possible. So I made sure that I was using validated tools. So I used muscle function assessments. So I used the SARC-F questionnaire and the hand grip, which was set out by Espen to sort of help me to deduce whether they have sort of probable sarcopenia. But it's quite difficult, obviously, because fatigue has a massive impact on muscle function. And helpfully, the physios do the 6-minute walk test. Otherwise, I might be with the patients for quite a while. So I use that input as well as working with the team to help to input into the nutritional assessment of the patient. I also use a validated malnutrition screening tool. So the beauty of this one, it was originally validated in patients experiencing cancer or renal disease. However, it's a beautiful tool and it works in multiple different populations, and it helps me just to clarify the extent of the patient's maybe if they're experiencing malnutrition due to various symptoms or a prolonged admission. A dietary intake assessment just to see how they're eating, what they're managing, what they're able to manage at the moment, because sometimes weight histories can be either the patient wasn't admitted, so weight history wasn't recorded, it was unable to get at the time, or the patient doesn't have an accurate weight history. So a dietary assessment intake is quite important, and seeing how that dietary intake has evolved over time. Gastrointestinal symptoms. So often these can either be new or they previously experienced them, but to a reduced degree, and also consideration of sort of nutritional deficits based upon symptoms, nutritional deficiency based upon symptoms. So I work quite closely with the consultant in the clinic, and we work together, and maybe a patient is experiencing a deficiency in a certain micronutrient, so we might help to deduce that and get the relevant tests and help them in that sort of area. Obviously, it is sort of a assess, evaluate, elimination, because every patient is really different, and that's something that I really want to focus on. And going in thinking there's a set criteria and a set thing to do is a completely wrong thing to do. So that question, is there a thing you can recommend for long COVID? The answer is no, it really is multifactorial with nutrition issues. So some of the 4 main sort of nutritional problems that we experience with that people are experiencing. So it's the unintentional weight loss, that's due to reduced food intake, due to symptoms. Now these symptoms can vary from breathlessness, not feeling like they're able to eat much at one meal. I think sometimes they can be gasping for air. It can be due to impact of reduced ability to swallow. Sometimes we have a speech and language therapist there, so that's really helpful in able to assess that, and then we can work together in evaluating what the best approach is to meeting that patient's nutritional requirements, while sort of making sure that their swallow is managed appropriately. And it can vary completely. Like many different patients have experienced inability to sleep at night, which can massively impact symptoms. On the other hand, we have patients who are previously quite fit, active, have quite active jobs, and they're almostly sort of incapacitated by their insatiable desire to sleep. So one patient I had was sleeping a large majority of the day, and that really impacted his ability to eat, as well as all the other symptoms. So he had a reduced window of opportunity to eat food, but also I think his weight loss was above 10%, which is quite significant. If anyone's aware of the muscle screening tool, that would give you a score of 2, so it would often in most areas trigger a referral to a dietitian. So the gastrointestinal symptoms, unknown cause. At the moment, we're just following standard protocol for that, so we're not assuming anything. We're doing the relevant tests to test for other conditions, and then obviously as these conditions eliminate, it might be for some reason IBS, which is another, again, an umbrella term and an elimination diagnosis, so that really doesn't add much clarity in that aspect. But the specialist dietitian in that area, I do rely on them quite a lot, and they help me quite a lot with, and often they take over the management of that patient once the diagnosis is confirmed. And I mean, I say some of the symptoms may be caused gastrointestinal, maybe caused to anxiety. They're usually related to the symptoms. So the symptoms people experience, and I think this is a really important thing that I've acknowledged quite a lot in clinic, is these patients will obviously previously quite fit and well. It was nothing they expected to happen, and they have a dramatic change in life, the inability to do tasks that they once took for granted. And it's a massive change in their life, and that can cause quite a lot of stress and anxiety, and especially when experiences with healthcare professionals have not been ideal, not been helpful, and also the fact that we don't know the answers, and I think that's upsetting. That's unsettling for us sometimes more than it is for the patients, but it is still quite unsettling unsettling for the patients that we don't have a clear answer of how long it takes to recover or how long it takes to do X, Y, or Z, and it really is person dependent. So one thing I've seen quite a lot in clinic is reduced muscle function. So often you could try and extrapolate that down to maybe a period of time during when they have the period of acute, if they've been in hospital, been hospitalized, obviously with various different treatments, it can impact your intake, reduced activity during that period of prolonged illness. Now, there is a correlation with a reduced muscle function in patients with who have not been hospitalized at all, and obviously through talking to them, probably many of people have experienced this, the massive change in the loss of taste and smell, the inability to eat food. I think one patient said, have you ever tried to eat chicken and it tastes just like, feel like you're eating just random flesh, and it's quite unsettling, or so that really does impact their ability to eat certain foods, and that can sometimes limit diet and reduce their ability to maintain or build back muscle after a period of illness where they haven't really eaten much. And then last but definitely not least is unintentional weight loss, and that can be due to activity, low mood, drastic changes in lifestyle, and that's just to name a few. So it's quite multifactorial in their reasons why they've had unintentional weight loss, and I think it's important to make sure those appropriate medical tests are done and work closely with the relevant specialist in order that you rule out those things, while also working on symptom management as well. But don't just think unintentional weight loss is because of long COVID. I would make sure everyone doesn't do that. I don't think, so that needs to be done. So suggestions. I think one of the things that patients have actually thanked me for in the clinic is acknowledging unknowns in this area. So the inability to know exactly what to do. And that's why I try to do as thorough assessment as possible, and I'd love to know what other people are doing around the country, other dietitians and other assessments are able to do. Diagnose nutritional issues and treat them as standard practice would be normally, to enable you to help the patient best, and don't assume anything, and make sure that you consult with the patient and ask relevant questionnaires. Use validated tools and assessments. I think that's been really valuable, because often, from my own experience, patients' improvements are quite slow, and it can be quite discouraging when they're expecting them to be well in, say, a couple of months, or so it's important to use validated tools, because the ones I've chosen, they have quite granular sort of representations of improvements, and sharing that with the patient helps them to understand whether an intervention is helping them or not helping them, or whether the benefits to that intervention are probably not helping, because some dietary interventions can have a impact on the life and cause stress, and I think that's important to acknowledge it too. So work closely with the other members of the MD team developing a nutritional plan. I think that's important. I mean, I've already mentioned the work with speech and language therapists to ensure that they're able to swallow appropriately. That's not an issue, and working with them to devise a relevant structure of meals, and just working around those kind of things to ensure that the patient gets the adequate nutrition that they need. But also making sure that the patient's seeing what other clinicians are doing with other healthcare professionals are doing with the patient, so ensure to adapt your plan accordingly. And then learning from patients. I think that's been something that I have joined a lot of the support groups, and I don't contribute to them, but I just sit there and listen to patients' experiences, and I think that's been really helpful for me to understand what the broader perspective is, because unfortunately clinics at a certain capacity, and we all know the limitations with various different funding models, but there's only a certain amount of patients that are possible for myself to see, and it's such a large problem that, I mean, it helps me to understand more about the condition and what other people are experiencing, and their other experiences that they've had, and what they're going through, and it helps to inform my care. I think also, I think one thing that I haven't put here, but I completely forgot about it, but I just remembered that it's important to make sure that patients understand what they're going through is other people are experiencing it too, and it's okay not to. Some of them may have eaten quite, they describe it as really healthily or perfectly prior to getting COVID, and subsequently that progressing into long COVID. They experience changes in diet and changes in habits that they sometimes feel like I'm going to come and tell them off for the food police. But I just want to make sure that's clarified. I mean, understand where you are and think about what ability you have to enable you to achieve a nutritional plan, and working appropriately with the appropriate individuals. I think various things like occupational therapy can be really helpful to enable people to develop plans in place to help them get the right amount of nutrition that their body needs in order to recover. I think one more thing that comes up quite often in just discussion groups and in questions asked to me, and also in the previous presentations about things like mast cell activation syndrome, and obviously we're aware it's a controversial area and it's quite difficult to get a diagnosis of this. But often what's discussed is antihistamine use, but also the use of a low histamine diet. Now, the British Dietetic Association has come out with, specialist allergy group has come out with guidance in relation to this. So you can find it online. It's freely available to any member of the public. So it covers lots of different things, but I think understanding that this diet has limited clinical actual trial, further trials are needed in the area. It's currently all anecdotal. I mean, do not follow this if you're at risk of malnutrition, because it is a really restrictive diet. And also, if we think about some of the symptoms that patients or you yourself may be experiencing, it might not be the best thing for you at that time, especially if you're struggling to obtain the adequate amount of nutrition. Adding extra restriction to that can actually be detrimental. There's lack of consensus of what are high and low histamine foods, which can be quite difficult. So it's important that you work with a dietitian and you do it for a fixed period of time, and you think of outcome measures that you can work with and help you to actually assess whether the diet's helpful or not. And if it's not helpful, then stop. And if it is helpful, then you can always think of a phased return back to a normal eating, and that's obviously probably best done with a dietitian, because there are risks and dangers to doing it by yourself without that sort of input from dietitian. And I also think there's many specialist GPs in the area that can talk a little bit more about this. But that's my end of my presentation. So any questions?
Thank you so much. It was almost like you read the speaker's, the viewer's mind there with a couple of the questions. So we're going to come for questions at the end, and over to Gemma. Thank you so much for your presentation. Gemma, over to you, please.
Hopefully this will
Yeah,
work. There we
got
go.
that. Lovely, thank you.
So as I said earlier, I'm Gemma. My clinical specialism is airways, and I work in a tertiary service. So that's generally where I've seen COVID patients or long COVID patients. But this presentation, I am speaking about sort of speech and language therapy and long COVID in quite broad terms. And I just wanted to mention at the beginning that although my focus is adults, I have clarified with some of my paediatric colleagues at centres around the country that the symptoms and the issues experienced by children with long COVID is very similar to the presentation of adults with the difficulties. So I think that there probably are kind of similarities, and what I'm talking about is relevant to both sets of people. So why speech and language therapy? Why should we be interested in long COVID? Why should people with long COVID want to know about speech and language therapy? We're experienced clinicians who can work with a range of people experiencing various different voice, speech, language, and swallowing difficulties, as Aaron's already mentioned, arising from a range of different disorders and health problems. We know, and it's been talked about this morning, that long COVID is a really complex multi-systems disorder. And it's becoming increasingly clear as time goes on that for some people with long COVID, this leads to symptoms that can very much be supported by speech and language therapists, whether it's something kind of fairly obvious like their laryngeal problems, or even kind of managing things like reflux that might be a gastrointestinal symptom. So what does the research tell us about speech and language therapy and long COVID? The answer is not necessarily very much at the moment. It's already been mentioned that there's so much still to learn about this condition. But there is a study that was published last summer, a survey of 702 people with, and this is really important, with mild to moderate COVID. So these were patients who may have been hospitalized but didn't go to intensive care, and a lot of them were at home, and they self-reported their symptoms, and unsurprisingly nearly 50% of them had dyspnea, so they had breathlessness or difficulties with breathing. Perhaps more surprisingly, over a quarter of these patients described problems with their voice, so dysphonia, and actually 17% of them had dysphagia as well, so difficulties swallowing. There was also a positive correlation between the dysphonia and the dysphagia. So in other words, if you had dysphonia, you were more likely to report difficulties with swallowing as well. There have also been a few case reports and case series looking at things like inducible laryngeal obstruction. So it used to be known as vocal cord dysfunction on the back of COVID infection. And we know that breathing pattern disorders are a problem. They're often dealt with by experienced and expert respiratory physiotherapists, but they can be managed by speech and language therapists as well, in the right centres with the right skill set. Interestingly, some of my colleagues who work in tertiary respiratory centres are reporting that actually chronic cough isn't as much of an issue as you might have expected following COVID infection. There are maybe a few people describing it, but that certainly doesn't seem to be the kind of main laryngeal symptom. So just quickly linking the research to the clinical perspective, there's a really complex interplay between breathing, swallowing, and voice. The larynx has three functions: one, to stay open, so the vocal folds to stay open in order to allow you to breathe; one, to close in order to allow you to swallow safely; and three, or the last one, for the vocal folds to vibrate in your throat in order to be able to produce voice. That system needs really quite intricate balance in order to be able to work effectively. And if anything disrupts that balance, whether that's viral infection, disordered breathing, reflux, then those functions will be impacted, and it may lead to muscle tension problems, breathlessness, and hypersensitivity. So this has huge relevance to long COVID patients. If you combine all of that with the issues of immune system shock, the post-exertional fatigue, the metabolic stress from the illness that they've had, it really isn't surprising that laryngeal issues are a problem. It also points to the importance of very thorough investigations into the cause of any underlying breathlessness. Because, for example, if the larynx is dysfunctional, or if there is any kind of muscle tension at the level of the larynx, then working on breathing may not be as effective as it should be, and might actually be counter-effective. What else does the research tell us about speech and language therapy? This is a preprint, so it hasn't yet been published or peer-reviewed, and it was developed from the patient-led research collaboration in long COVID. And why it's obviously interesting to me as a speech therapist is that nearly half of their 3,762 respondents reported some kind of speech and language therapy issues in more general terms, like word finding difficulties or difficulties processing text. There have also been a couple of case studies looking at the sort of more acquired disfluency or stuttering that patients have described as a result of COVID infection or long COVID. And we don't necessarily know why people have these problems. And I know that there's a panel later in the day talking with a great deal more expertise than I can about long COVID and the neurological impacts. And many of these difficulties may be able to be managed very effectively by our occupational therapy colleagues or our neuropsychology colleagues as part of general cognitive change or the brain fog pattern that we know patients with COVID have. But there might be a small but significant group of patients who have a more specific focal neurological difficulty that would benefit from speech and language therapy input. And we really do need to be mindful of that as we continue to learn about long COVID and think about the services that are necessary. So what are patients telling us? This was a blog written in the BMJ by 2 doctors and a voice professional about the laryngeal symptoms that they were experiencing and that they had talked about on long COVID forums. So we know that they're there. Patients are describing hoarseness, difficulties with their voice, difficulties with swallowing. This idea of the COVID strangle, which actually is an airway speech therapist, is a term that I maybe haven't heard put in exactly those words before, but isn't unusual to me. Again, if you have any kind of degree of laryngeal hypersensitivity or discomfort, or you've had any sort of insult to that area of the body, a change in, having something around your neck can feel incredibly suffocating and threatening, or lying flat where the structures change shape and alter slightly, you can suddenly feel far more breathless, or far more as though, it takes you back mentally to a place that you were when you were very acutely unwell. So it's not unusual, and this is something that I really do believe that we can help with. And I think these quotes for me, when I was looking for sort of what patients are saying about the sort of more traditional speech and language problems, show the power of social media. It's how I first heard about long COVID, and it gives you an immediate snapshot of the problems that move beyond the sort of traditional symptom profile and what we're hearing about in the media. And again, it just suggests that there really is a need for speech and language therapists to be engaged, and for long COVID patients to know about us as a profession and what we might be able to do to help. And again, whilst speech and language therapists aren't always within a long COVID clinic, there are plenty of clinics that do have a speech therapist with them. Lizzie, the psychologist who's about to speak, I know that she works with Lorna, who's a fantastic speech therapist doing brilliant work with long COVID patients. And when I reached out to colleagues who were in these settings to ask them what they're seeing, it's very clear that there's a wide variety of different symptoms and problems that speech therapists are able to help with and support, and there really is a need for us to be in those settings. The interplay between mental health and fatigue and the symptom profiles that we're seeing with speech and language therapy is also really key, and working alongside our multidisciplinary colleagues to make sure that we're well supporting patients is really very, very important. And I've highlighted this quote from one of my colleagues because it's just really powerful to me. Just because something is mild doesn't mean it isn't distressing for a patient, and it doesn't mean it should be kind of brushed under the carpet because it isn't the severe symptom that you would perceive needs some sort of therapeutic input. If something is distressing for the person in front of you, then you need to work with it and help them through it. So just a few slides about what do you do then with patients with long COVID. I think what Aaron was talking about, being honest, is really key. If you don't know the answers, or you can't give a trajectory of recovery in a time frame because it's long COVID, that's okay. It's all right not to know, and it's far better for the person that you're working with to kind of feel that you're in it together, learning, as you go along, than be told something that doesn't prove to be the right answer. Being curious, so asking the right questions at the right time for your patients, but also recognizing that you need to be flexible within that. They might not know the answers straight away. You might not know the answers straight away. And similarly, their needs may change over time, and you might meet them and initially they feel that they don't need speech and language therapy input because their voice problems whilst they're there aren't causing them any difficulties, but they might then return to work a few months later and that suddenly becomes much more of an issue. And I think we really need, as much as possible, to offer patients the opportunity to kind of reach back into our services, even if at the sort of initial contact time you weren't the key professional for them. Instrumental assessment is really important. It's very valuable, but if you can't access it because there's a waiting list or because you work in a relatively isolated setting, then just remember all of your clinical skills. Remember what you know as a clinician, and and use those to help support your patients. And a good example of that would be, listening to a patient history, working out the pattern of their voice difficulties. Is it a kind of generalized vocal fatigue throughout every single day, or does it build up over the course of a week, which would indicate maybe it's more related to the generalized fatigue that we know happens with long COVID. And teamwork, working with your own multidisciplinary team if you have one, reaching out to long COVID clinics if you're not embedded, just to let them know that you're there and what you can potentially do if they want to refer people to you. Talking to local GPs and primary care trusts just about what can be provided from a speech and language therapy perspective is really important. And in terms of managing people with long COVID, there was a quote that came from the NIHR report on the lived experience that I felt was really powerful. The idea of recovery being a roller coaster and not an incline, that this is not a condition where you just gradually improve over time and you go from kind of A to B and it's relatively straightforward. It has this relapsing remitting profile. So, one day you might feel okay. And that does need to be considered when you're managing speech and language therapy difficulties, because as I already said, things will change for patients over time. And one week they might have lots of issues with their voice, for example, and another week not so much. It's also really important to just talk about the benefits of self-management and autonomy. So things like your COVID recovery profile can be really helpful, but that sometimes as clinicians, we need to be there to support patients in that self-management, and leaving people in isolation to kind of just get on with their own therapy is perhaps not always the right choice, but it's about what the individual wants and recognizing their priorities along the trajectory based on the demands that they have in their life at any one time. It's also really important to remember that this is a condition where symptoms can be, one symptom might improve and another symptom might develop. So as we've already said, we just need to constantly be flexible and adaptable and recognize that things change really quickly, and that we can support with that. And, if you want more specifics about, say, the laryngeal symptoms and how you can manage those, again, go back to your clinical toolkit. It's not different to managing anybody with laryngeal issues. Use symptom diaries to see if there's particular triggers for laryngeal symptoms. So is there anything that causes their hypersensitivity or a sensation of blockage in their throat? Making sure that their vocal hygiene, so water and steaming, avoiding caffeine, all of those things are as relevant. Using things like laryngeal deconstriction techniques, desensitization, really important. And just make sure that you are offering the patient a space to be believed, because that is so powerful and so important. And then just to end, in terms of considerations for speech therapy provision, there's huge variability across the country. But I guess what I want to do is to empower people living with long COVID to know that they can go to their GP and ask to be referred if they feel that it would be helpful for their symptoms, or be within a long COVID clinic where there isn't a speech therapist and ask if there is potential for a speech therapist to be involved in their care, or an ENT doctor if that's necessary from a laryngeal perspective. We need data, we always need data. So if you are working with patients with long COVID, please collect it, please write it up, please put it out there, contact Royal College. We just need to know what these patients need from us. And, as a speech therapist, recognize the worth that you have, don't overstate it, work within your teams, recognize that we are so much more powerful together. Thank you.
Wow, a couple of powerful statement points in that presentation. Gemma, thank you so much. You're hanging around for the Q&A at the end. Lizzie, I am going to come down to you next. Thank you so much for the next and final presentation of this session. Thank you.
That's great. Thank you. I'll just get my screen up. Okay, that's on. Can you hear me and see that, Rachel?
Yes.
Okay, super. So yes, I'm a clinical psychologist, Lizzie Davey. I work in a physical health psychology service in North Cumbria, and I'm working into the long COVID service as a member of the MDT in that area. I'll just give a little bit of context to our MDT. So we are funded as I think we all are as an assessment service, but we don't offer the one-stop shop model of assessment. We're a rural location. And we also think that with the fatigue that many of the patients have, it can be quite challenging for them to come and be assessed by everybody at once. So we have a system of screening, initial screening assessment, following which people with long COVID can be put on different pathways to see different members of the team. And we have a fortnightly virtual MDT where we can discuss those pathways and needs and share information. Core members, physios, speech therapy, as Gemma mentioned, 1 day a week of me as a clinical psychologist, but I'm supported by 2 part-time assistant psychologists, and we have living well coaches who do a sort of a social prescribing role as well as part of the team. And then on the periphery of that, we can refer into a number of other clinics and to a number of other groups. So just thinking about what we're seeing. So I'm going to present this in terms of my experience of working into that service. So the main issues that we're seeing really are the anxiety and depression, and that's what the surveys of people with long COVID are showing up, that there's a roughly 30 to 40% prevalence of anxiety and or depression as part of long COVID. And actually, that's quite similar to what I see in the rest of my work. The rest of my working week, I work with long-term conditions, cancer, respiratory, cardiac, diabetes, and you actually see roughly 30–40% of anxiety and depression alongside those conditions as well. So in terms of the anxiety, I think that Erin and Gemma have both mentioned, distress as part of their talks. This is something that's there alongside the physical symptoms that people are having. There is a lot of uncertainty still around long COVID. It's new. We're not able to tell patients with any sort of definite prognosis at the moment. We can't guarantee full recovery. We're still all learning as part of this. And as part of that, there's then a lack of information for people about what might be out there, what might be happening for them. A lot of people we see have a level of fear of recurrence. So they worry about picking up COVID again and having another acute illness and then becoming even more unwell. They see these kind of relapsing presentations sometimes, as Gemma described, as that sort of roller coaster where things get better for a little while, but then they get worse. Perhaps there's an acute infection that leads to a relapse of symptoms, and that can lead to people being quite fearful. And there's links into some of the traumatic events that happen as part of people's original acute illness. We've seen quite a bit of low mood as well, often connected to the losses that people have. People tend to have a big reduction in functioning, and that can impact on their identity and on their work role, their role within family, within other relationships. We see quite a lot of hopelessness about the future and helplessness for what people can do to change. There's an impact in body image. We've talked to a number of people who've had hair loss, often several months after the initial COVID, weight gain, weight loss, changes in skin, lots of issues that relate to the body image and how people feel about themselves. And there can also be some guilt, particularly when a number of family members have had acute COVID, and we've seen people where some family members may have died and others haven't, and people can blame themselves in terms of transmission of the original infection. And with trauma or PTSD, we know that about 2 out of 3 patients in ICU will experience delirium. So they'll have confusion, they won't know what's going on, they may hallucinate, they may be delusional. And we're seeing a lot of that in the people at ISS that I'm working with, who were referred to see me as a psychologist. And usually they don't really know what that is and what's caused that. Breathing difficulty, so patients who have had significant issues with breathing and have struggled to get a breath have found that very traumatic. And that's true of people who have COVID at home and not just those who have it in hospital. And also a large number of the people I'm seeing with trauma report that they nearly died. They all anecdotally tell of family members being called to say goodbye. They'll be told that maybe they've got a 50-50 chance if they get put into an induced coma. They'll say of comments from doctors like, oh, we thought you were a goner there. And that also adds to the post-traumatic symptoms that we're seeing. So what does that actually look like in patients? So yes, it impacts on breathing and voice difficulties, as Erin said, also on diet, on eating as well. So what we're seeing is actually the anxiety can be secondary to people being unwell with long COVID, but also it can then exacerbate a lot of the other symptoms that they're having. People with anxiety are often quite avoidant. They might avoid going out. They might avoid activities. There's often a short-term relief in anxiety in avoiding doing things, but unfortunately that contributes to its longer-term continuation maintenance. We'll see patterns of anxious thoughts and also disturbed sleep in people, particularly when they're getting wound up and stressed. And unable to then drop off to sleep. With depression, typically people will appear flat, low, tearful. It has a big impact on motivation, and it adds to a loss of interest in doing activities and therefore a reduction in activity. And it can have a significant impact on relationships. With the trauma, the key things are people having flashbacks to a traumatic event, often hospital-based, but could be, as I say, at home in terms of breathing, nightmares, which disturb sleep. And then the avoidance around trauma is very often of the incident, the traumatic incident itself. So people reporting that they're meant to be going in for blood tests, but they don't really want to go into the hospital location. And that's where us doing lots of our work virtually with people can be of benefit because they feel a lot more comfortable to sit in their own homes and join an appointment via a video link than be asked to come back into hospital, particularly if it's for a long clinic. And trauma is also associated with intrusive thoughts. So what are we doing to help? Well, we're really lucky that our MDT, most of the members of our MDT have actually already pre-COVID done psychosocial skills training, CBT skills training. This is something that is recommended with a lot of colleagues who work with long-term conditions, and it came out of Cancer Pathways, where all team members are seen as having a role in supporting patients' psychological needs. So we've got a good programme in place already across Cumbria of training our AHP colleagues. So to support patients as well, a whole team is involved in explaining and normalising long COVID and the symptoms, admitting what we don't know, but also saying what we do know, and what we're seeing across a lot of people is really validating what's going on for patients. The team's also involved in assessing and treating the physical symptoms that people are presenting with. And that's hugely important to people's emotional well-being, knowing that they're being cared for and looked after and supported, and that they're starting to then see some improvements in those symptoms. And in particular, some of those really overlapping symptoms with anxiety, depression, so breathing, sleep, fatigue difficulties are all being worked with across the team. And mindfulness is something that we will all talk to people about, and everyone knows a couple of apps to share and recommend. So specifically with anxiety, as a psychologist, and I'm supported in work with anxiety and depression by the assistant psychologists in the team. So we help people to recognise those links between the thoughts, our emotions, the symptoms in our bodies, but also our behaviours and what we're doing, and recognise how we can get trapped in vicious circles around those. We do some of the basic explanations and education around anxiety, the physiology of anxiety, or fight or flight, as it's called. We'll work with people with a stepped plan for increasing activities, thinking about what causes least anxiety first, and then increasing gradually to support them to achieve more. And that's very much based on their values-based goals, so what the individuals want to achieve and not any set goals from us as a service. And also to help people to identify those anxious thoughts, to look for themes in their anxious thoughts so that they can help to predict them and observe them and step away from them and manage them in a much more confident way. With depression, we're supporting people, behavioural activation, so helping people doing more enjoyable activities is one of the most common ways of working with depression, but we're doing that bearing in mind the fatigue and the post-exertional malaise that many of our patients have. So we really start small with that, something small but enjoyable every day, something for themselves. People with limited energy often waste that energy trying to get chores done or do things for other people, but actually, with depression, there's a need to look after yourself first sometimes. We help people work around acceptance and adjustment, with the new them and the changes to identity. We help people plan for the future, so look to decrease that hopelessness and helplessness by giving some idea that there are options and that people are improving. I think the majority of people on our pathways continue to make progress. It is often slow progress, but we aren't really seeing people plateauing and stopping yet. People, once they're getting the support, are continuing to improve. And also supporting with self-compassion and self-care. With trauma, the first thing is just to educate around what PTSD is, what trauma is, what ICU delirium is, validating, normalizing those experiences. And then with some patients, we progress to EMDR, which is eye movement desensitization and reprocessing, which is a trauma therapy, and that will help to process and unstick the traumatic memories that patients have. And there's a couple of techniques in there for any psychologists out there. So RTEP is a recent events protocol. So this most recent wave of hospital admissions, the ones from earlier this year, we'd be looking to do that kind of work with them. Flash technique is a sort of an earlier phase of doing EMDR that doesn't involve people having to really open up the stressful, distressing memories. So what have we learned so far? Well, one of the things, this learning was really started from last summer when we were seeing people from the first wave coming out, and they were showing really significant symptoms of trauma initially, and I was setting them up to do work with them, but by the time they kind of came back to do that work, they were saying, oh, actually I feel a bit better, I'm doing a bit more, I'm not having so many flashbacks. So we're recognizing that trauma symptoms do actually reduce naturally in the early stages. So we're assessing, we're giving the information, and then we're inviting people to come back after a few weeks to see if things are changing by themselves. With depression and low mood, we're seeing that really follows the physical symptoms and functioning. As functioning increases, so does the mood. When people have flare-ups, mood dips as well. And having that initial screening with our colleagues in the team and making a plan and receiving physical treatment, a lot of the people, by the time they come to their psychology assessment, are already reporting improvements in mood, reduction in anxiety, because they know they're getting support, they're getting input from the service, and they start to feel more hopeful about the future. So coming to an end now, just here's some comments from my colleagues about the impact on the broader team, and they find that having psychology embedded in the MDT is really useful. It speeds up the support, it helps everyone have a kind of psychological mindset to the work. It allows my colleagues to get on with their own work roles because a lot of the distress is managed by the psychology part of the team. And just to end, I think what's really stands out for me, and when I follow information on long COVID on social media and so on, is psychology is there as part of the MDT to support with the psychological impact of people for living with this new and at times really scary condition. It's not as part of the MDT to suggest that long COVID is anyway some sort of psychosomatic illness. And really the work I'm doing is the equivalent of the work I'm doing with people with cancer, with people with diabetes, with people with COPD, with people who've had heart conditions, to help them to live with the psychological impact of those. Thank you.
Thank you so much, Lizzie, and thanks to all the speakers for being, sorry, bang on time. We've got 10 full minutes for questions before we go in for a break. Now, I'm going to kick off with the questions before moving over to Raz. Gemma, questions for you. I mean, there was lots of comments, and I suppose thanks of your validation for these voice issues, the little, I almost done it there myself, the little feeling of something in your throat, constantly needing to clear your throat, asking for advice, but saying like it's just in your head, or drink water, or so. I think just thanks for that. There's a question from a physio, and I did direct them to a couple of people to the podcast we done the other night about the swallow and the interlinks with breathlessness. But at what point do you refer on for these laryngeal dysfunction type issues? And I mean, it's an intricate balance between the breathlessness and the dysfunctional breathing pattern that we're seeing, and abnormal breathing patterns, but at what point would you refer on?
I guess, I mean, if you're an experienced respiratory physio and you're working with a patient and they aren't improving, that's the most logical time to start thinking maybe something else is going on here, especially if and I think this is particularly true for the non-hospitalized cohort of patients, because the ones who've come from intensive care admissions or even just hospital, the chances are they will have actually been through some sort of ENT assessment, particularly if they've been, and they'll be being followed up by the kind of post-ICU clinics. In our trust, we've got a follow-up for kind of anyone who was tracheostomized within ENT, they get seen by us. So it's the people who are sort of at home that I'm most concerned about that might be missed. And so I guess it's just, if you start thinking this usually I would be seeing some kind of gains by now and it's not happening, then, you know, flag it up with speech and language therapy colleagues if you have links to them. And I think that's why the links are so important. Or if you don't have that, speak to the patient's GP about getting them referred into ENT, just to be kind of absolutely sure that there isn't anything else going on.
Thank you. And quite often that's what the speech and language therapists will say, won't they? If there's any kind of airways issues or any chance of any abnormality, first get checked out by ENT, and then they're very good at referring on to you guys, aren't they? Once they've worked out any diagnostic or structural abnormalities. So Raz, over to you, please.
Thank you so much, everyone, for all their talks. It was really interesting. Aaron, just a couple of questions for you. I guess for anyone who's listening who is a healthcare professional, if someone is coming in saying they want to follow a low histamine diet, what does that actually look like? What does that mean? And I think there's been some variation in the comments about some people saying they've been experiencing weight gain, some people have experienced weight loss. Why do you think this variation exists, and how can we prevent the weight gain and weight loss? Oh, I think Aaron has disappeared. Okay, maybe I'll go on to Lizzie first. Lizzie, I'll ask you a question. Oh, Aaron, you're back.
He's back. Sorry, I didn't know who iPad was, so I've just took a massive gamble admitting someone into the.
Sorry, my computer just went pop. I don't know what happened. It just went off, and I started to panic. Sorry.
Did you hear the question, or do you want me to repeat?
Can you repeat the question, because I didn't hear it at all?
Not a worry at all. So the first question is just, what does a low histamine diet look like? Maybe some examples would be great. And just with the variation in some people losing weight, some people gaining weight, why do we think this variation exists, and how can we prevent significant weight loss and gain?
So I do want to clarify further on the low histamine diet, and I'll answer the question, but I'll do a non-answer the question. So the current consensus is very different based on different resources. So there is actually no consensus on what a low histamine diet actually consists of. Mostly in my clinic, I have never recommended the low histamine diet to a patient. It's never been required or indicated. However, I have had patients come to the clinic who maybe were following a low histamine diet previously. So I think of a couple of patients, and one of them experienced massive amounts of weight loss and a massive malnutrition risk. And when discussing with her, it wasn't the low histamine diet; it was the issue. It was the fact that she was losing weight quite dramatically, and so we went off that. And secondly, the one that did go on a low histamine diet that actually had benefit, had actually sought out dietetic support prior to seeing myself in the long COVID clinic, and was on the low histamine diet as guided by a dietitian, and they actually received some benefit. A lot of patients will come to clinic and not receive any benefit. So I just wanted to, the reason why I shared it is just to make sure that everyone's aware that the guidance document from the BDA is not a guidance document to tell you exactly what a low histamine diet is. You'd probably require a specialist allergy dietitian to indicate that. However, sorry, my room's getting quite hot. So, however, it's important to acknowledge that this is anecdotal perspective, and there's currently I know of a few dietitians trying to pull together outcomes related to that, because there is really no evidence apart from anecdotal evidence. And I know in the previous presentation, Dr. Khan's preliminary results, also from the multiple doctors, do talk about lots of people experiencing from people with long COVID experiencing benefit from that diet. So I just wanted to make sure those clarifications were there, and it's not, yeah. And I also wanted to apologize to everyone and say the document is actually behind a restricted wall for only BDA members, but it doesn't provide any guidance on how to follow the low histamine diet. That would probably be best done by a specialist allergy dietitian. Hopefully that answers the question. Sorry, I can't really answer the question, what is a low histamine diet, because I don't want to. What was the other questions?
Sorry, I did throw a lot of questions at you at once. It was just about the variation between weight loss and weight gain, and what we can do to be preventing significant weight loss and weight gain in these patients.
So I think those that are hospitalized, I think ensuring that, so one of the biggest issues with patients who are hospitalized is they might come in, they might not be regular visitors of healthcare, there might not be a weight history for them on the system, so they might not be flagged up by traditional screening tools. I know a lot of hospitals use the MUST screening tool, and that incorporates BMI as one of those major criteria. And if your BMI is not low, you're going to have to wait a couple of days before you actually don't eat anything or a little bit before you get referred. And we know that patients who are on varying degrees of oxygen therapy do struggle to actually get enough food in. So I would say proactive referrals to dietetics would probably be the best way forward. And I know different hospital systems, there's lots of limitations to that, because it would obviously boost the amount of referrals. I know it was quite hectic, and I know some places have gone into using things like protocols based, so based on various different indicators indicating support with nutrition through oral nutritional supplements, or offering of various snack menus or things like that, be set in place just to do the limitation of dietitians, the physical presence of dietitians.
Jump in there, sorry. What about for the long COVID cohort as well? So patients.
So the long COVID. So patients who aren't in hospital have long COVID. So, I mean, it's just, I think, first of all, entirely preventable. I'd probably say it might not be preventable. You might just lose weight. And obviously I could say things like encourage, have little, and try to have a little bit of food, try to eat foods that you can manage. A little bit of something is better than having the ideal food. So just try to eat as little as you, not as little as you can, little and often when you're ill, as much as you can when possible, just to ensure that you're getting enough energy. And I would probably go for, depending on your appetite, I'd probably go for the foods that are slightly higher in energy, because I'm assuming that you're probably not going to eat very much of it. So it's just ensuring that you get that as much energy as possible, and just Also thinking about after the illness, thinking about managing that, and it depends how long it goes on for, because it might require a dietitian to sit down and look at your diet and then work with you together to think about how you can input more. Maybe it be an element around ensuring that you have a good amount of protein and also a good amount of energy in your diet if you're experiencing weight loss.
Definitely. I think it shows the complexity of COVID. Some people lose weight, some people gain weight. It's quite unpredictable. Lizzie, just coming into you quickly. We know that COVID patients and the links between health inequalities are certainly there. Has there been anything that you've done that you've changed your practice to take this into consideration?
In terms of the health inequalities, I guess one of the big things I think I said early on is we are a very rural area. It can lead to kind of an unequal ability to kind of access services. So we're really trying to look into how, and this has been throughout the whole of the last year in all of our services, you know, how do we help all of our patients, all the people that we're working with access services? And we're really thinking about trying to be as accessible as possible. So the old traditional model of people having to travel into a hospital or clinic site to come and see us, trying to make sure that we're able to do virtual appointments, telephone appointments, trying to arrange our appointments at times that suit the people that we're working with, and give as much flexibility as possible.
Thank you so much for those wonderful questions, Raz. And I think that just shows the complexity, like you said, of COVID and long COVID, and about making sure healthcare is accessible to all. We've done a whole series special podcasts on nutrition, on speech and language therapy. We haven't done one on psychology, Lizzie. So if that's something that people think that they need, please do reach out. I'm up for anything. And it also shows us that we need to be really inclusive with what we're offering. And we did do a podcast specifically on learning disabilities as well. So there is time for a longer half-an-hour break. You're going to get a full half-an-hour break now. So please join us back at 1 p.m. Please reach out on Twitter to all of these wonderful people who will answer any of your questions moving forward. It's such a hard thing to fit in an entire profession in 15 minutes. So I'm super grateful. Thank you so much.